Imagine walking into your doctor's office in, say, 2025 and getting a diabetes diagnosis that's not just type 1 or type 2, but like something way more specific, something truly personalized, you know?
Yeah, like tailored to you.
Exactly. And, well, that future might be closer than we think.
Oh, for sure.
We're diving deep today into the American Diabetes Association's 2025 Standards of Care in Diabetes,
Right.
focusing on Section 2, which is all about diagnosis and classification.
Okay, yeah,
So, are you ready to kind of decode the future of diabetes care?
absolutely. I'm really excited to dig into this. This publication really pushes those boundaries.
Mhm.
It goes beyond the typical type 1 and type 2 boxes and embraces like a much deeper understanding of this whole complex condition.
Yeah. So, like, the report kind of reminds us that diabetes is more than just high blood sugar, right?
Mhm.
What's the bigger picture we should be thinking about?
It's not just about the sugar. Diabetes is really a whole group of metabolic disorders,
Yeah.
and they mess with how your body uses carbs for energy. What I find super interesting is that the ADA report highlights how diabetes can actually lead to both underutilization and the overproduction of glucose in the body.
So, it's not just about like lowering glucose,
Yeah.
but also about like how the body's using it.
Yeah, exactly.
Wow.
Which opens up like a whole new world for personalized treatment.
Yeah. Okay, that makes sense. So when it comes to actually diagnosing diabetes, we're still using those familiar tests, right?
Yeah.
A1C,
Yeah.
fasting plasma glucose,
Hmm.
and the 2-hour glucose tolerance test.
Right?
I noticed something in the report about those tests, though. It said that the tests don't always, like, match up perfectly.
Ah, yeah.
What's that all about?
You've hit a key point there.
Yeah.
Each of those tests reflects a slightly different aspect of your glucose metabolism.
Really?
Yeah, so you might have an A1C that suggests prediabetes, but then your fasting glucose is totally normal.
Hmm.
This is why doctors really need to look at everything together. Combine those test results with your own personal factors and medical history.
It's more like putting together a puzzle than just, like, looking at one piece.
Exactly.
Okay. So let's move beyond type 1 and type 2 for a minute.
Okay.
One type that's gaining recognition is monogenic diabetes.
Yeah.
It's caused by a single gene mutation and often diagnosed pretty early in life.
Often, yeah.
So this is like literally written in your genes.
It is.
What does that mean for treatment? Like, how does that change things?
Imagine this. Someone's taking daily insulin injections. Then, boom, genetic testing reveals they actually have monogenic diabetes.
Okay.
With that new knowledge, they could possibly switch from those injections to pills.
Wow. Okay.
It's a perfect example of how powerful personalized medicine can be.
Absolutely. It shows how crucial genetic testing can be to getting that right diagnosis and figuring out the best treatment.
For sure. And beyond that, there are other types of diabetes out there too.
Oh, really? Like what?
Well, there's pancreatic diabetes.
Yeah.
It's also called type 3C. It
Right.
comes from damage to the pancreas and is often misdiagnosed as type 2,
Oh, wow.
which again emphasizes why these more specific classifications are so important.
So damage to the pancreas can actually cause diabetes.
It can, yeah.
What would cause that kind of damage?
A bunch of things, actually.
Like what?
Pancreatitis,
Okay.
trauma to the pancreas,
Oh, wow.
or even pancreatic cancer. Basically, the damage stops the pancreas from producing insulin, and that leads to diabetes.
So are there other types we should know about?
They also discuss cystic fibrosis-related diabetes in the report,
Okay.
which throws another wrench in things for people already dealing with cystic fibrosis.
Yeah, for sure.
And then there's post-transplantation diabetes mellitus, which shows up after an organ transplant.
Oh, wow. That sounds complicated. What are the big challenges with that one?
The report talks about the tough decisions doctors have to make with post-transplantation diabetes because the drugs they use to prevent organ rejection can also increase the risk of diabetes. It's a constant weighing of risks and benefits.
You're basically walking a tightrope to find the right balance, right? Like between preventing rejection and managing blood sugar.
Yeah, exactly. It just shows how personalized care is so crucial in those situations.
Speaking of personalized care, the report also dives into screening recommendations, like who should be getting screened and when.
The ADA guidelines are very specific, but it's not like a one-size-fits-all approach.
Right, of course.
Things like your age, weight, family history, ethnicity, and even certain medications all play a role in how they assess your risk.
So it's about tailoring the screening process to you based on your own risks.
Exactly.
This feels like a good time to talk about type 1 diabetes.
Okay.
What are some of the takeaways from the report about type 1?
Well, there's been some really cool progress in diagnosing and managing type 1.
Oh, like what?
Autoimmune markers and genetic testing are getting more and more important for catching it early, even before symptoms show up.
Wow. So they can actually identify someone who's at risk before they even feel sick.
Yeah, that's the idea.
That's amazing.
And get this, there's research happening right now looking at ways to slow down or even prevent type 1 diabetes in people showing early signs of autoimmunity.
So we could actually stop it from ever happening.
That's the hope. It would totally change the game for anyone predisposed to type 1. The report also breaks down type 1 into 3 distinct stages, which helps us understand how it actually develops.
3 stages. I'd love to hear more about that. But first, did the report say anything about COVID-19 and diabetes?
Oh, good question.
Like, is there a connection?
There is emerging research suggesting that COVID-19 might trigger type 1 in some people. It's definitely something to watch as research continues.
It feels like there's always something new to learn about diabetes.
Always.
Okay, before we go to the next part of our deep dive, let's talk about prediabetes and type 2. What are some of the key points the report makes about these conditions?
Prediabetes is super important to understand. It's that stage before someone develops full-blown type 2, a warning sign, basically.
What exactly is prediabetes? Why is it such a big deal?
Basically, your blood sugar levels are higher than normal, but not high enough for a diabetes diagnosis. But people with prediabetes are at a much higher risk of developing type 2 and other problems like heart disease and stroke.
So catching it early is critical.
Definitely.
What does the ADA recommend for screening?
They really stress how important screening is. Early detection can make a huge difference in stopping it from becoming type 2. They even changed their criteria for prediabetes. Now, A1C levels between 5.7 and 6.4% are considered a marker.
So are the risk factors for prediabetes and type 2 the same?
Many are familiar, like obesity, inactivity, and family history.
Okay.
All those increase your risk.
They all kind of work together too, don't they?
Yeah, definitely.
Now, back to monogenic diabetes for a sec. We talked about how treatment can change based on genetic testing.
Right.
But how do you even know to get tested in the first place? How is it diagnosed?
The report really emphasizes early genetic testing for this.
So if someone thinks they might have it, what should they do?
Talk to their doctor about getting tested.
Okay.
It could literally change how they manage their diabetes.
Mm-hmm.
Like, in some cases, a genetic test could mean the difference between taking insulin every day or just popping a pill.
That's amazing. Personalized medicine is changing everything.
It is.
Okay, last thing before we move on. Gestational diabetes. What are the key takeaways about that?
That's a fascinating one. The report digs into the complexities of it and the long-term impacts for both mom and baby.
So what really stood out to you about gestational diabetes?
Well, there's this debate about the 2 main screening strategies.
Yeah.
The report talks about both, but acknowledges that there's still a lot of discussion about their effectiveness and costs.
2 different strategies. Okay, we'll have to unpack that.
We will.
We've covered so much in this first part of our deep dive into the ADA's 2025 standards.
We have.
We talked about different types of diabetes, some we knew and some maybe not so much.
Yeah.
And we really dug into the changing world of diagnosis, screening, and treatment.
Definitely.
It's clear that personalized medicine is becoming more and more important,
For sure.
and there's hope on the horizon with all the research focused on preventing type 1.
It's an exciting time.
It is. It's also a little
A
overwhelming.
little bit, yeah.
We'll continue exploring all of this in the next part of our deep dive, so stay tuned.
Definitely. Welcome back.
So I'm ready to talk about those 2 screening strategies for gestational diabetes. What makes them so different?
Okay, well, one is called the one-step strategy.
Mm-hmm.
It uses a 75-gram oral glucose tolerance test, an OGTT.
Yeah.
It's given between 24 and 28 weeks of pregnancy.
So just one test at a certain time. Got it. What's the difference?
The key here is how you interpret the results. Even a small bump in blood sugar during the test can lead to a gestational diabetes diagnosis. So you get more diagnoses with this one than with the other approach.
Interesting. So it's more sensitive in a way. Picks up more cases.
Exactly.
What about the other strategy, the 2-step? How does that one work?
So the 2-step starts with a 50-gram glucose challenge test. You don't even have to fast for this one.
Oh, that's good. Fasting when you're pregnant can't be fun.
Yeah, exactly. So what happens next?
Well, if your blood sugar's high after that first test, then you go on to a 100-gram OGTT.
Okay.
And that one you do have to fast for. It gives a more detailed look at your blood sugar control.
So it's kind of like a screening test first,
Yeah,
and then a more in-depth one if you need it. I can see how both approaches have their pluses and minuses.
for sure.
What are the main pros and cons for each one?
Well, the one step is definitely easier, and it might catch more cases.
Okay.
But some doctors worry that it might lead to overdiagnosis. Maybe some women are getting diagnosed and treated who don't really need it.
Yeah.
A two-step, well, it might miss some cases.
But it means not everyone has to do that harder fasting test. It's a tricky balance.
Yeah, there's always something to consider.
Right.
So what does the ADA recommend? Which strategy do they favor?
They actually lean toward the one step, mainly because it's based on actual pregnancy outcomes, which makes sense.
Right.
They do admit that there's still debate, though,
Of course.
and they say more research is needed.
Always more research, it seems.
It never ends.
So, stepping back for a second, why is gestational diabetes even a concern? Like, what are the risks?
It can cause problems for both the mother and the baby.
Like, what kinds of problems?
Well, for the mother, it increases the risk of high blood pressure, preeclampsia, and maybe needing a C-section.
Those are some serious complications. What about the baby? What risks do they face?
Babies born to moms with gestational diabetes are more likely to be large for their gestational age,
Oh, okay.
which can make delivery harder. They're also at risk of low blood sugar after birth and might even need to spend time in the NICU.
So it's really important to manage gestational diabetes carefully during pregnancy.
It is.
Does it just go away after the baby is born?
That's a good point. It usually does go away after delivery,
Okay.
but it's kind of a warning sign.
A warning sign, like for what?
It means you're much more likely to develop prediabetes or type 2 diabetes later on.
So even though it's temporary during pregnancy, it can have lasting effects on your health.
That's right. That's why the ADA says women who've had gestational diabetes should get screened for diabetes for the rest of their lives.
Yeah.
It's all about staying on top of it.
Makes sense. It's about understanding your risks and taking steps to minimize them.
Yeah.
This is making me think about all the different types of diabetes besides type 1 and type 2.
Right.
Like we talked about pancreatic diabetes,
Yeah.
type 3C.
Yeah.
What makes that one so unique and why is it often misdiagnosed?
Well, pancreatic diabetes happens because the pancreas is damaged.
Right.
And that damage stops it from producing enough insulin. The damage could be from pancreatitis, trauma, or even pancreatic cancer.
So it's not like type 1 where your immune system attacks the pancreas. This is about actual physical damage.
Exactly. The tricky part is that many people with pancreatic diabetes are also overweight or obese.
Like people with type 2.
Yeah, exactly. And that overlap can lead to the wrong diagnosis.
That makes sense.
Yeah.
So how do doctors tell the difference? What are some signs that point to pancreatic diabetes?
If someone's had pancreatitis or other pancreatic issues, that's a big clue.
Okay.
Also, signs of pancreatic insufficiency.
Pancreatic what?
Insufficiency.
Yeah.
That means the pancreas isn't making enough digestive enzymes,
Okay.
which can lead to problems with digestion and absorbing nutrients. Basically, it's a sign that the pancreas isn't working the way it should.
So it's not just about insulin, it's about the whole pancreas.
Exactly. And if a doctor suspects pancreatic diabetes, they can do specific tests to check how well the pancreas is functioning.
Sounds like a lot of detective work to figure out the right diagnosis.
Sometimes it is.
Okay, we also mentioned cystic fibrosis-related diabetes.
Yeah.
Is that connected to pancreatic damage too?
It is. It actually comes back to that pancreatic insufficiency we just talked about.
So people with cystic fibrosis are already dealing with pancreas problems.
Yeah.
And then on top of that, they can develop diabetes too.
Unfortunately, yes. It makes things even more challenging for them.
I bet. How does it usually happen?
Well, cystic fibrosis is a genetic disorder, right?
Mm-hmm.
It affects a lot of organs, including the lungs and pancreas.
Right. I remember learning about that. Something about thick mucus.
Right, exactly. Thick mucus is a hallmark of cystic fibrosis. And that mucus can block the ducts in the pancreas.
Okay.
So those digestive enzymes can't get to the intestines.
I get that part.
Right.
But how does that lead to diabetes?
Over time, that blockage damages the pancreas.
Including the cells that make insulin.
Exactly. And as those cells get destroyed, diabetes can develop.
Wow, it's like a domino effect. So how do they diagnose cystic fibrosis-related diabetes? Is it the same process?
Well, there's a bit of a twist. The A1C test, the one we talked about earlier, it's not as reliable for people with cystic fibrosis.
Really? Why not?
Their red blood cells turn over differently than people without cystic fibrosis.
Okay.
So it can mess up the A1C results. make them less accurate.
So what do they use instead?
They use an oral glucose tolerance test,
Right.
the 2-hour OGTT. It gives them a clearer picture of how well their blood sugar is being controlled.
Interesting. Again, it shows how important it is to tailor the diagnosis to each person's situation.
Absolutely.
Okay, last one for this part. Post-transplantation diabetes mellitus. What's the most important thing to consider when managing that type of diabetes?
The report really stresses that it's a balancing act.
Balancing what exactly? What are the factors doctors have to consider?
You have to balance the risks of diabetes with the risks of organ rejection, because the drugs they use to prevent rejection can actually increase the risk of diabetes. It's a tough situation.
Yeah, it's like a catch-22. You need the drugs, but they might cause another problem.
Exactly. Doctors have to carefully watch blood sugar levels and adjust medications to find that sweet spot.
It's all about finding the right balance, isn't it?
It really is.
This whole conversation has highlighted the role of genetics in diabetes.
Yeah.
We talked about how genetic testing can reveal things like monogenic diabetes, which can totally change how it's treated.
Right.
But what about for the more common types, like type 1 and type 2? If diabetes runs in your family, does that mean you're definitely going to get it?
Not necessarily. It definitely increases your risk, but what you do, your lifestyle choices, those still have a huge impact.
So it's nature and nurture.
Exactly. Knowing your family history can help you make smarter choices about your health.
You can take control of those risk factors that you can actually change.
That's the key.
Well, this brings us to the end of part 2 of our deep dive.
Wow, time flies.
We've learned about all sorts of diabetes types, explored the ins and outs of gestational diabetes, and I think it's clear that personalized medicine is the future. What's next on our journey?
In part 3, we're going to go even deeper into type 1 diabetes, exploring those 3 stages we touched on earlier. We'll also talk about some of the amazing research that's happening right now.
Welcome back to our deep dive, everyone. I'm super curious about those 3 stages of type 1 diabetes you mentioned. How it actually develops over time.
It's pretty fascinating stuff and super important when we think about prevention, So stage 1 is all about autoimmunity.
Okay.
This is when you start seeing those autoantibodies in the blood,
Right.
even if their blood sugar is still normal.
So no symptoms yet, but their body's getting ready to attack the pancreas.
Exactly. It's like the groundwork is being laid, but you can't see it yet.
And what are those autoantibodies exactly?
Good question. Think of them like little flags. The
Mhm.
immune system uses them to mark cells for destruction. In type 1, those autoantibodies target the cells in the pancreas that make insulin. It's like the immune system is confused,
Yeah.
thinks those cells are the enemy, and it wants to get rid of them.
So stage 1 is like a silent phase. Everything's happening under the surface.
Exactly. Then, in stage 2, you start to see dysglycemia.
Okay, what's that?
Dysglycemia just means blood sugar levels are starting to go wonky.
Wonky, huh?
Yeah, like up and down, outside the normal range. But not high enough to be diagnosed with diabetes yet.
So like a pre-diabetes stage specifically for type 1.
Exactly. And the thing is, people move through these stages differently.
Yeah.
Some folks might stay in stage 2 for ages, while others zoom right to stage 3.
So everyone's experience is different. And stage 3 is when they actually have full-blown type 1.
Yep. That's when the damage to those insulin-producing cells is so bad that blood sugar is consistently high.
Wow. It really can sneak up on you. Makes early detection even more crucial.
Absolutely. If we can catch people in stage 1 or 2, maybe we can do something to slow it down. Maybe even stop it from progressing to stage 3. That's where all that research on immune modulation comes in.
Yeah. You mentioned the possibility of delaying or preventing type 1. What are researchers working on?
There are lots of trials going on right now.
Okay.
Some are trying to retrain the immune system, stop it from attacking those pancreatic cells. Others are looking at ways to boost the body's own defenses against autoimmunity.
It's amazing to think we might be able to prevent type 1 altogether.
It would be huge.
Yeah.
It's early days, but the results from some of these trials are pretty encouraging. Imagine, kids who are at risk could get treatment to protect them. They wouldn't have to deal with insulin injections every day. That's the dream.
That really would be life-changing. This has been super informative, but I'm also thinking about, the human side of all this. Does the ADA report talk about the emotional impact of a type 1 diagnosis? That's got to be tough.
Yeah, it's a big deal. And the report actually does address that. It
Yeah.
acknowledges the emotional roller coaster that comes with the diagnosis, especially for type 1. They emphasize the need for support,
Yeah.
psychological resources for people with diabetes and their families.
Because it's more than just managing the physical stuff. It's about the mental and emotional burden, too.
Exactly. Diabetes affects everything, your daily routine, your long-term plans, everything. Having support and access to mental health resources is so important for coping with that.
It really is a whole person approach to care. So, wrapping up our deep dive into the ADA's 2025 standards of care, what are your final thoughts?
I think the biggest takeaway is that we're constantly learning more about diabetes. Those old categories of type 1 and type 2, they're not enough anymore.
Yeah,
We need to look deeper, recognize all the different subtypes, how genetics and lifestyle interact, and how we can truly personalize treatment.
it's exciting even though it's challenging, right?
Totally. And as we've seen in this deep dive, knowledge is power. The more we know about diabetes, the better we can manage our health and make choices about our care, now and in the future.
Well said. And for our listeners, as you continue learning about diabetes and how to manage it, think about this. With all these advances in personalized medicine, how might your approach to healthcare change? What steps can you take to understand your own risks and maybe even explore those preventative strategies we talked about? It's definitely something to think about as we wrap up our journey into the future of diabetes care.